Hello, my name is Phil Pereira, and I'm the Emergency Ultrasound Coordinator at the New York Presbyterian Hospital in New York City. And welcome to Soundbites Cases. Welcome to Soundbites Ultrasound, focusing on the imaging of the hepatobiliary tract. Bedside ultrasound of the gallbladder allows rapid evaluation of patients presenting with acute abdominal pain to the emergency department, and gallstone-related disease is now more commonly diagnosed in the ED, secondary to the increased use of ultrasound scanning at the bedside. Interestingly enough, gallstone-related disease is not only seen in traditional female population as described in textbooks. As we start to look more and more with bedside ultrasound, we're often diagnosing gallstone-related disease in men who have rapid weight changes and in the elderly. As there's a lot of information to cover with regard to the hepatobiliary tract, I've divided this module into hepatobiliary parts 1 and 2. In this module entitled Hepatobiliary Ultrasound Part 1, we'll begin by reviewing the anatomy of the liver and also of the gallbladder. We'll then move to learn how to perform the hepatobiliary ultrasound examination, looking at both the liver and also the gallbladder. We'll learn how to review the imaging findings of the liver and the gallbladder essential to bedside ultrasound, and then we'll conclude this module with a discussion of the examination of the portal triad. Let's begin with a clinical case that highlights the utility of bedside gallbladder ultrasound. Our patient is a 40-year-old female presenting to the emergency department complaining of right upper quadrant and epigastric abdominal pain after eating a burrito. We review her vital signs and notice that she has a mild tachycardia of 104 and a temperature of 100.8. On examination, she has palpation tenderness in the right upper quadrant area of her abdomen, and labs come up back. She has a white count of 11. Her lipase and LFTs are within normal limits. So, because of the fact that gallbladder disease is very high on the differential, let's go through the spectrum of disease that encompasses the gallbladder and biliary tract. We'll begin by identifying asymptomatic cholelithiasis, or the presence of gallstones without symptoms. Now, that's going to be present in a majority of the population, and many times gallstones will not cause problems through a patient's life. However, a percentage of the population will develop symptomatic cholelithiasis, or gallstones that cause pain, with biliary colic often seen after eating a fatty meal. Unfortunately, a segment of these patients with gallstones will develop acute cholecystitis, or infection of the gallbladder, usually due to an impacted stone at the gallbladder neck that doesn't allow for outflow of bile into the biliary tree and sets up for an infection within the gallbladder. Interestingly enough, a subsegment of the acute cholecystitis patients will have a waxing and waning course with chronic cholecystitis. Now, a worse disease is choledocholithiasis, when a stone moves from the gallbladder down into the biliary ducts and can cause obstruction of the biliary ducts, resulting in ascending cholangitis, a very severe infection. If the stone goes down to the ampulla vater, where the pancreatic duct joins the biliary duct, a patient can get gallstone pancreatitis, which can also be a very severe disease with high morbidity. Let's begin by reviewing the anatomy of the liver and gallbladder. Here we see the liver and the gallbladder tucked in the inferior aspect of the liver. And this is a very nice illustration from Ultrasound in Emergency Medicine by Simon and Snowy in 1997. We also see the portal triad connecting the gallbladder and the liver down to the intestine, and notice the pancreas here tucked into the C-arm of the duodenum. We see the biliary tract emptying into the duodenum and joining with the pancreatic duct at the ampulla of vater. Here's the normal appearance of liver on bedside sonography. I'm placing the probe in the traditional right upper quadrant fast view. I have the probe marker towards the patient's head, so superior to the left, inferior to the right. The large structure we see in the middle of the image is all liver. And we see superior to the liver, the curving white line, which is the diaphragm, and inferior to the liver, the football-shaped kidney. Let's take a closer look at the liver, and we note that it has a salt and pepper type configuration. Note the absence of any significant masses within the liver, and also the absence of any free fluid or ascites surrounding this liver. So a pretty normal liver on bedside sonography. Here's an ultrasound image showing an abnormal liver in a patient who had pancreatic cancer and liver metastases. Again, I have the probe marker towards the patient's head, superior towards the left, and inferior towards the right. Let's look at the superior aspect of the liver, and what we notice here are several mets, the white round areas right below the diaphragm. So an abnormal appearance of a liver with metastatic disease. Here's another worst case scenario showing an abnormal liver on bedside sonography. What we see here is that the parenchyma of the liver is now replaced by a cystic type appearance. Unfortunately, this patient had disseminated cancer to the liver, and this was a very abnormal appearing liver. So first of all, I want you to be able to recognize the differences between a normal liver on bedside ultrasound and one, like this clip and the previous, where you must get further imaging to further diagnose what the patient's condition is. Here's an interesting image showing intrahepatic ductal dilatation in a patient who had biliary obstruction. And what we see here is the appearance of dilated biliary ducts crisscrossing through the liver. And as we see here, the liver now has a channel-like appearance. We call this the antler sign, as what it appears like is the ends of the dilated biliary ducts look like antlers on a moose. And we see a normal liver shown to the bottom right here. Notice the normal liver has none of this crisscrossing channel-like appearance that we see with intrahepatic ductal dilatation. So another finding that should trigger you to get another imaging study, as this is an abnormal liver. Now let's review the hepatic and portal veins. We see the portal vein coming in at the bottom of the image, bringing oxygen-rich and nutrient-rich blood from the intestines for filtering by the liver. We see it branching into the right portal vein and the left portal vein. Notice the hepatic veins at the top of the image, and remember that the hepatic veins drain the filtered blood from the liver into the inferior vena cava. We see the three hepatic veins, the right hepatic vein, the middle hepatic vein, and the left hepatic vein. Recall that the hepatic veins divide the liver into the four lobes, and we can see here the right posterior lobe and the right anterior lobe, divided by the relation of the right hepatic vein to the middle hepatic vein. We also see the left medial lobe and the left lateral lobe, which again are divided by the left hepatic vein in relation to the middle hepatic vein. Knowing the location of the hepatic veins and where are the lobes of the liver can allow us to determine where a lesion lies within the parenchyma of the liver. And this is a very nice illustration from emergency ultrasound by Cosby and Kendall in 2006. Here's an ultrasound image showing normal liver vasculature. The probe is positioned directly below the liver with the probe marker over towards the patient's right. We see the inferior vena cava towards the bottom of the image and the portal vein. Notice that the portal vein has echogenic or whiter walls due to the greasy material within the portal vein coming from the intestine. We see the branches off the inferior vena cava making what appears to be a bunny rabbit sign. The left hepatic vein, the middle hepatic vein, and the right hepatic vein. Now, knowing the location of the hepatic veins, we can now target where are the lobes of the liver, and we see the left lateral lobe and left middle lobe defined by the relation of the left hepatic vein with regard to the middle hepatic vein, and the right anterior lobe and right posterior lobe defined by the relation of the right hepatic vein to the middle hepatic vein. But note again the difference between the portal vein with its white or echogenic walls and the hepatic veins, which have a darker appearance on sonography. Here's a classic appearance of the portal vein as it branches into the right and left portal veins within the liver parenchyma. Notice again that the liver is seen here in the middle of the image and that the portal vein has echogenic or white walls. I'll still that down, and here we see the branch points between the right and left portal veins. But note again the very dense or echogenic white walls of the portal vein due to the fact that it's bringing the greasy blood to be filtered by the liver from the intestine. Now let's learn how to perform gallbladder sonography. There's two main positions for performance of the gallbladder ultrasound exam. Let's begin with the first position as shown in probe position 1. This is known as the high lateral view, where we're looking through the ribs. Basically, we're in a position very close to the right upper quadrant fast position, but in a more mid-sagittal location or towards the patient's midline. We angle the probe a little bit more anteriorly to be looking at the gallbladder, and we get some great high lateral views of the gallbladder. The second position is to roll the patient into the left lateral decubitus position and then place the probe as shown here in the subcostal position with the probe marker over towards the patient's right side. This also can give great views of the gallbladder and allow for assessment of the sonographic Murphy's sign. Remember to rotate the probe to both long and short axis views from both of those positions. Now let's watch a video on how to perform gallbladder sonography. We'll begin with probe position 1, the high lateral view of the gallbladder. We begin by placing the probe into the traditional right upper quadrant fast area. We then bring the probe more anteriorly or towards the mid-sagittal location of the patient up onto the abdomen. We can then flatten the probe or aim it more anteriorly, and the gallbladder will usually pop into view from this position. Once the gallbladder is found, we can then rotate the probe so the probe marker is over towards the patient's right shoulder to get the full effect of the gallbladder from fundus to neck. And here I'm just showing the location of the high lateral view of the gallbladder, and notice that the probe marker is over towards the patient's right shoulder. We can see the nice images in the picture within the picture to the bottom left. Now we should also look at the gallbladder in both long and short axis views. Notice here I'm just rotating the probe over into the short axis configuration to also look at the gallbladder in another plane. It's always good to look at the gallbladder from another position. This is known as probe position 2 or the subcostal view. Notice that the patient is in the left lateral decubitus position with the right side up, and the probe is placed into the subcostal position with the probe marker over towards the patient's right side. We can get great views of the gallbladder and also push directly on the gallbladder to assess for the sonographic Murphy's sign. Let's now review the gallbladder anatomy that's important for gallbladder sonography. Here we see the gallbladder to the top left, and remember the parts of the gallbladder: the uppermost superior fundus, the body encompassing the majority of the gallbladder, and the neck as seen to the top here. Remember that it's stones that become impacted at the neck that can cause obstruction of bile from flowing out into the cystic duct and can set up for acute cholecystitis. We see here the cystic duct draining the neck of the gallbladder and joining into the hepatic duct. Remember that the hepatic duct brings the bile directly out of the liver. Once the cystic duct joins into the hepatic duct, the duct becomes the common bile duct as shown to the lower aspect of the image. Recall that the pancreatic duct, bringing pancreatic secretions, joins into the common bile duct at the ampulla of Vater to dump the secretions into the second part of the duodenum. Here's an ultrasound image showing a normal gallbladder. We appreciate the liver to the left, and directly beneath the liver we see the pear-like structure of the gallbladder. Now, directly below the gallbladder we see the pipe-like inferior vena cava. Now we see some rib shadows from the top emanating down towards the gallbladder, but as we scan through the ribs we get a pretty good view of all parts of the gallbladder. I'm going to still the image down here, and we see the fundus of the gallbladder towards the right and the neck of the gallbladder towards the left. Recall that stones that get impacted at the neck of the gallbladder can cause acute biliary colic and, worst case scenario, acute cholecystitis. But here we see the absence of any stones within this normal gallbladder. One of the findings that can be commonly seen on bedside sonography is a septated gallbladder. Here we see a septated gallbladder with a septi coming through the middle of the gallbladder. Now this is a completely normal congenital finding and not to be confused with gallstone or cancer or any other type of gallbladder pathology. Note here the absence of any significant gallstones within this normal septated gallbladder. It's very important to delineate the gallbladder versus other structures that may appear like the gallbladder and be seen within the right upper quadrant. Here's a pitfall. This was a cystic structure within the liver that mimicked a gallbladder. But as we look further at the cystic structure and compare it to the normal gallbladder seen to the right, we note that it has jagged walls, is located within the liver, and fails to have the normal pear-like type appearance of the gallbladder as seen in the mini video to the right. So just make sure that when you're looking at the right upper quadrant that you've correctly identified the gallbladder and not mistaken it with another cystic structure that could be coming from the liver or the kidney. Now, a very important landmark for gallbladder sonography is the portal triad Mickey Mouse sign. And what we see here is the relation of the gallbladder to the right to the portal vein to the left. And the portal vein again will be denoted by its echogenic or bright walls. Now, in between the gallbladder and the portal vein is a very important structure of the liver known as the median lobar fissure. And often, if we're struggling to find the gallbladder, we can find the portal vein and walk our way up using the MLF to the gallbladder. Note the structures on top of the portal vein, the common bile duct as seen to the left there, and the hepatic artery as seen to the right. This makes up the portal triad, and we'll show video on this in upcoming slides. Here's the portal vein exclamation dot on bedside sonography. Note here we see the gallbladder to the right, the portal vein as shown to the left with its hyperechoic or bright walls, and note the white line that joins the gallbladder to the portal vein that is the median lobar fissure. And that's a very important structure within the liver that can help us guide from portal vein up to gallbladder. It also ensures that you've inspected all the way to the neck of the gallbladder for any small stones. Now in the background we can see the inferior vena cava moving up and down as the patient breathes. So exclamation dot sign, gallbladder to portal vein, hooked in between by the median lobar fissure of the liver. Here's another ultrasound image to reinforce the median lobar fissure of the liver as a very important landmark that joins the gallbladder to the portal vein. We see the gallbladder to the right or inferior and the portal vein with its echogenic or bright walls to the superior aspect to the left. Notice the little white line, which is the median lobar fissure, well seen in between the portal vein and gallbladder. Here's video showing the relation of the gallbladder to the right to the portal vein, and we see the portal vein with its echogenic white walls, and in between that we see a white area which is the median lobar fissure of the liver. And again, it's very important to visualize the MLF because therefore you know that you've walked your way from portal vein up to the neck of the gallbladder and fully inspected that neck of the gallbladder for any small stones that may be causing symptomatic cholelithiasis. Now let's review the portal triad and its relation to the gallbladder. We see the gallbladder to the top of the image underneath the liver, and we see the common bile duct draining the gallbladder down into the duodenum. Notice that the common bile duct comes down to the left of this image, but would be located over towards the patient's right as we examine a real-time patient. Notice that the portal vein is the posterior-most part of the portal triad and is located behind the common bile duct and the hepatic artery. We also see here the hepatic artery, while located towards the right of this image, would be in real time towards the patient's left side. Here's an interesting finding on bedside sonography known as the Mickey Mouse sign or the ultrasound appearance of the portal triad. We see the gallbladder towards the left here, and notice the portal vein, the larger structure, towards the bottom of the image. On top of the portal vein, we see two structures making up the Mickey Mouse ears. The common bile duct making up Mickey's left ear, and the hepatic artery making up Mickey's right ear. Remember here, the probe is configured in a transverse axis with a marker dot towards the patient's right side. If we put Doppler flow through Mickey, we see Mickey's face, the portal vein, does have Doppler flow. We see Mickey's right ear, the hepatic artery, also having Doppler flow, but we note the absence of flow within Mickey's left ear, the common bile duct, as the common bile duct only has sluggish flow that is not well seen with bedside Doppler. But the ultrasonic appearance of the Mickey Mouse sign with Doppler sonography. And again, you can see Mickey's face, the portal vein, and the hepatic artery and common bile duct making up Mickey's ears. Here's a video clip showing a dilated common bile duct and pericholecystic fluid in a patient with pancreatic cancer. Now in this view, the probe is angled a little bit more towards the patient's right shoulder. We can see here the pear-like structure of the gallbladder. We can see a little stripe of fluid outside the anterior wall of the gallbladder as seen to the top of the image, making up pericholecystic fluid. But the important findings here are note the portal vein in long axis, we see here towards the bottom of the gallbladder, and on top of the portal vein we see the common bile duct. Notice the inferior vena cava also visualized towards the bottom of the image. Now, as we've configured the probe in a little bit more of a long axis, we see the common bile duct and portal vein as parallel channels, one on top of the other. Here's the same patient. Now we're putting Doppler sonography onto that area of the portal vein and common bile duct. Note that the portal vein has flow on Doppler sonography, but that there's absence of flow within the common bile duct. And this is another way that you can differentiate CBD from portal vein. Now in terms of some dimensions of the common bile duct, generally we're going to measure from inner wall to inner wall of the common bile duct, and a normal common bile duct should measure no more than 1 millimeter for each decade of the patient's life. A common bile duct which measures greater than 8 millimeters is universally enlarged. Also by convention, measurements of the common bile duct are taken from inner wall to inner wall. Here's video from a patient who had a dilated common bile duct. The probe is configured in the long axis orientation, so we see the parallel channel or shotgun sign made up of the portal vein to the bottom of the image and the common bile duct on top of the portal vein. What we see here is that as the CBD enlarges, it becomes almost as big or larger than the associated portal vein. We see the Doppler image to the right and notice that there's Doppler flow within the portal vein, but an absence of any Doppler flow within the CBD, further differentiating the two structures. So the parallel channel or shotgun sign usually associated with a dilated common bile duct. So thanks for joining me for this Soundbites module covering bedside ultrasound of the gallbladder in Hepatobiliary Ultrasound Part 1. My conclusion points and goals of this module: I hope now that you understand the anatomy of the liver and gallbladder essential to bedside sonography and know how to perform the hepatobiliary sonography examination. Also, you know how to interpret the hepatobiliary sonography images correctly that you will obtain from bedside ultrasound of this area. So I hope to see you back as we return with Hepatobiliary Ultrasound Part 2, focusing on gallstone disease, where we'll look at the spectrum of disease from gallstones on to acute cholecystitis.